And how will you grade power? So because we are moving on to the motor power grading and motor functions. Now cranial nerve is over. Now we are going to the motor. So what are the different aspects of power grading? How will you grade power? So what is the definition? This is the MRC grading of power. Okay, I think I have given already in your papers. So 0 stands for no contraction. 1 stands for just a flicker of contraction. 2 stands for full active range of movement, but without again not against the gravity, but after eliminating the gravity. So patient will have active movement, but after eliminating gravity. After eliminating gravity, correct? So number 3, active movement against gravity. Against gravity, but not against resistance. If you give any sort of resistance, they cannot move, but they can spontaneously move against gravity itself. 4 means there will be active movement against gravity and resistance. Gravity and resistance. Active movement against gravity and resistance both, but not normal power. Active movement against gravity and resistance, but not normal power. So how will you say this? Only when you compare this with the opposite side. Then only you will be able to say. Otherwise, it's very difficult to define 4 in the first place. You have to compare the opposite. It's not normal power. Slightly less, but they are still able to perform movements against gravity as well as against resistance. In that itself, some neurologists give 4 minus. What is 4 minus? Slight resistance. Against slight resistance. 4, only 4 means it is moderate resistance, and 4 plus means it is significant resistance. Okay, strong resistance, but still it is not normal power compared to the other side. So that's called 4 minus, 4 and 4 plus, and 5 is normal power. So how will you grade reflexes? 0 stand for absent reflex. There's absolutely no reflex. If you tell plus or minus, it means it's present, but only with reinforcement. Only with reinforcement maneuvers, like Jendrasic maneuver, you will be able to get the reflex. Otherwise, you will not be able to get the reflex. 1 plus means reduced reflex, depressed reflex, hypokinetic or hypoactive reflex. 2 plus means it's a normal reflex. 3 plus means brisk reflex. 4 plus means brisk reflex with clonus. 4 plus is with clonus. It's a brisk reflex, but there is clonus as well. It's a brisk reflex, but there is a clonus. That is 4 plus. And in the summary, if you see, for upper limbs, we have multiple movements. What are the movements you are going to minimally perform in exam? Minimum, what these are the movements you have to perform. In exam, you have to tell all these movements. One is shoulder abduction. And remember, as I said already, human has a typical pattern of distribution. Whenever you talk about human, it has a very typical distribution pattern. It supplies certain groups of muscles and does not significantly involve in certain group of muscles. So if it's a shoulder abduction, yes, it is significantly affected by human fibers, which means in a human lesion, this will be definitely affected, shoulder abduction. They can't do that. Root value for shoulder abduction is C5, very important. And whether is there any reflex associated with shoulder abduction? No, you don't do any reflex with shoulder abduction. What is the nerve that is supplying shoulder abduction? Predominantly axillary nerve. Yes or no? And the muscle that helps in shoulder abduction is deltoid. Up to 90 degree, but okay, beyond 90 degree it's serratus, but up to 90 degrees deltoid. First 15 degrees supraspinatus. But I'm talking about exams. Okay, so you should not talk too much also like this. We all know that first 15 degrees supraspinatus, up to 90 deltoid, then after that there is serratus. It's fine, but deltoid is the muscle. And next is, once you finish off the shoulder, we have elbow flexion. Elbow flexion. Elbow flexion, it is not supplied by human typically. It is not a area that is well supplied by human, and the root value is C5, C6 for if it's a biceps, and if it's C6 if it's a brachioradialis. Depends. It's biceps means it is C5, C6. If it's brachioradialis means it is C6. Reflex, yes, for both you have a reflex. For biceps also you have a reflex, and for brachioradialis also you have a reflex. Biceps is supplied by whom? Muscular gluteus nerve. Brachioradialis is supplied by radial nerve. Remember, biceps flexes the elbow in supine position, and brachioradialis flexes the elbow in semi-pronated position. Okay, this is the action of brachioradialis, and this is the action of biceps. Like when you do dumbbells, that is actually biceps. Okay, in semi-pronated position, if you are doing something like this, that is what? That is for brachioradialis. So you have to thank biceps or brachioradialis. He's telling both. Okay, good. Fine. Then you have what? Elbow extension. Elbow extension. Yes, it is significantly affected by the human distribution nerves. Root value is C7 for the triceps. Triceps, it is C7. Reflex, there are not. Yes, definitely yes, you can do a triceps reflex. And who's supplying the triceps? Radial, because not almost all the extensor compartment is supplied by the radial nerve only. And this is a high radial nerve. Okay, on the top itself you will be getting supply. And wrist extension. Wrist extension. Do you have a reflex for this? Yes. Okay. And sorry, it says affected by human. Yes, it's affected by human. You do not have a reflex here for wrist extension. Only supinator has a reflex. Wrist extension doesn't have a reflex. And what muscle is responsible for this radial wrist extension? Radial wrist extension. Radial wrist extension means you're going to extend the wrist, but radially like this. Okay, that's called radial wrist extension. Because it's extension, definitely it must be what? Radial nerve only, and supplied by a muscle, and it is because of the muscle called extensor carpi radialis longus. ECR. Extensor carpi radialis longus, or extensor carpi radialis. So movement should be extension along with deviation to the radial side, radial deviation. That is the ideal movement. Then next is going to be finger extension. Finger extension. Finger extension, once again, it is C7 only. Okay, what is the muscle that is responsible for finger extension? In fact, two muscles. One is extensor digitorum. Yeah, I think communist. But anyway, extensor digitorum only. Extensor digitorum is the one that is going to be responsible for the finger extension. Human distribution, definitely yes. There is no reflex associated with finger extension, and the radial nerve only supplies this also. Okay, radial nerve only supplies, but one branch of the radial nerve is there. What is that? Posterior interosseous nerve. One branch of the radial nerve is there. Posterior interosseous nerve. That is the one that's going to be responsible for this. It's going to supply extensor digitorum, and then we have something called finger flexion. Okay, this is not human distribution actually, and the root value is C8, and there is a reflex, finger flexion reflex. Everyone knows. You can keep the hand here and you can tap it. I'll show you. That's a finger flexion reflex. And who are the ones that are responsible for finger flexion? So finger doesn't mean only finger. You have thumb also. So you have to include thumb flexion as well as finger flexion altogether. Thumb flexion is mediated by flexor pollicis longus. We call it as FPL. That is the name that we use. That's called flexor pollicis longus. Then for index finger, we have flexor digitorum profundus. Okay, why I'm splitting separately is because flexor digitorum profundus and flexor pollicis longus are basically supplied by anterior interosseous nerve, which is a branch of the median nerve. Posterior interosseous nerve is a branch of radial nerve. Anterior interosseous nerve is a branch of median nerve. So that is why I am writing anterior interosseous nerve. And remember, the lateral, the medial two, heads of the flexor digitorum profundus is supplied by ulnar nerve and not median nerve. Okay, so that's what. And then all other flexors are there. All other flexors supplied by median nerve. As I told you, ulnar nerve is going to supply the ring and the little fingers. These two, the medial two is supplied by ulnar nerve specifically. The flexor digitorum profundus. It is FDP only, but for ring and little fingers. Ring and little fingers, it is the ulnar nerve. Okay. Then coming to finger abduction, I'll tell you the clues in a while. I'll write this first, then I'll tell the clues. Finger abduction. Finger abduction, yes, it's a very important area supplied by UMN. And it is a T1 nerve root because you are going to have dorsal interosseous. You would have studied pad dab mnemonic, no? Dorsal interosseous for abduction and palmar interosseous for adduction. So dorsal interosseous. And another thing that's going to help in abduction of the thumb is abductor pollicis brevis. That's called APB. Abductor pollicis brevis, APB. And there is no reflex located for this area. We don't have any reflex, which is designed. Actually, dorsal interosseous is supplied by ulnar nerve and abductor pollicis brevis is supplied by median nerve. So how I'm able to say these things pretty easily? It's very simple. I have a map. So what map I have? It's because if you take the intrinsic muscles of the hand, okay, these are the common clues. Intrinsic muscles of the hand, whatever small muscles you have, not the longest muscles, but the brevis muscles. Okay, not longest. Whatever muscles, intrinsic muscles you have in the hand, these are T1 nerve root. Okay, whatever muscles that are intrinsic to the hand, within the hand, not coming from outside. Okay, like FDP, FDS. I'm talking about only intrinsic muscles of the hand. They are supplied by T1 nerve root. This is a common nerve root. All are supplied by T1 and all are supplied by ulnar nerve. Everything is supplied by ulnar nerve. Except what? Except four muscles. These are called as loaf muscles. Okay, these are called as loaf group. So what do you mean by loaf? Lateral to lumbricals. Lateral to lumbricals. Okay. Not intraossei, but lateral to lumbricals. Lateral to means here, these two lumbricals near the thenar eminence. O stands for opponent's pollicis. A stands for abductor pollicis brevis, not longus. Longus is outside. It's not intrinsic muscle. Brevis. Then flexor pollicis brevis again, not pollicis longus. Remember, flexor pollicis longus also supplied by median nerve only, but I'm talking about the intrinsic muscles of the hand. These four muscles are supplied by median nerve. Okay, except remaining all the intrinsic muscles of the hand are supplied by ulnar nerve only, except loaf muscles. Are you able to understand or not? So my mind map is very simple. Anything in the extensor compartment along with brachioradialis, what is the nerve supply? Radial nerve. All the intrinsic muscles of the hand except loaf muscles are supplied by whom? Ulnar nerve. In the forearm, only one muscle ulnar nerve is supplying, that is lateral, medial two heads of the flexor digitorum profundus for the ring and the little fingers. That is the only thing that is supplied by the ulnar nerve in the forearm. Plus every single supply of ulnar nerve will be for the intrinsic muscles of the hand except for the loaf muscles. Then remaining everything is what? Median nerve in the forearm and wrist. So that is why I am able to write so fast and easily. So simple. It's not a difficult thing at all. So just have a mind map. So what you are trying to talk about. So in the arm, it is even more easier. Okay, your biceps and biceps is normally supplied by muscular goodness nerve. Triceps is supplied by radial nerve, and brachioradialis is supplied by radial nerve as well. And there is no median nerve supply actually in the arm, basically. And deltoid is supplied by axillary nerve. We all know that. So that we can understand everything. So this much, if you know, it's enough. And then what about, and one more important thing is, if you can see here, I've told you some particular human distribution. Okay, here. I've shown you some human distribution here. These are no certain things only. As you can see here, what are the things that are supplied by human? Abductors and extensors of the upper limb. Yesterday I told you, remember, extensors of the upper limb and flexors of the lower limb are supplied by whom? Predominantly by human. They have a high human innervation. Likewise, abductors of the upper limb and extensors of the upper limb are getting high level of human innervation. That is why when you see, whenever the patients go for stroke, human stroke, in old age and all, when they don't do physiotherapy, what happens? What happens when you don't do physiotherapy? So their hands will go like this. That is because of human paralysis. Normally, abduction and extension are typical human distribution. So they go for flexion and they go for adduction close to the body. That is because of overactive of extrapyramidal tracts. That is the reason. Okay, that's why. And you have seen in many movies also, no? In the movies, one problem is immediately after stroke they'll go like this. That is different. But generally it takes a bit of time. It doesn't happen so fast. But anyway. Okay. What are the movements in the lower limb? So first you can notice hip flexion. I told you in lower limb, flexors of lower limb. So definitely hip flexion is one of the things that are extremely well supplied by human nerves. I told you already. And what is the muscle that is responsible? Iliopsoas. Iliopsoas. And root depends actually. Basically it is L1, L2, L3 root wise. It can go up to L4 depending on what you're dealing with. And you don't have any reflex basically for iliopsoas. Cannot do any reflex. But depending on what segment you're dealing with. So if you are dealing with psoas major, then it is directly L1, L2, L3 spinal nerves. Straight away they come. Or if you're dealing with iliacus component, then it will be supplied by femoral nerve. Femoral nerve is L2, L3, L4, as you all know. Femoral is L2, L3, L4, depending on what component you are dealing with. Iliacus supplied by femoral nerve, whereas your psoas component is supplied by directly by L1, L2, L3 spinal nerves itself from there on. Next, coming to hip adduction. You know, hip adduction is typically, you know, like obturator compartment, that is adductor compartment. We have adductor magnus, longus, brevis. You have a lot of adductors, isn't it? So basically, you have a separate group of adductors which are the medial compartment of the thigh, as we all know. And of course, your nerve that will be supplying is obturator nerve. Okay, obturator nerve is the one that is the nerve of the medial compartment of the thigh. And reflex, no reflex is associated with obturator hip adduction. And human, no, there's no typical human distribution. Then you have L2, L3, okay, nerve root. That is the nerve root. Then coming to hip extension. See, obturator reflex is something that can be done, but honestly speaking, we don't do it. Yeah, that's why I told hip adduction, obturator reflex can be done, but we don't do it clinically. We don't do it in practice, but it can be done if you want. There is a method to do, but in exam, you're not going to commit on obturator reflex and hip adduction reflex. You're not going to do that. That's why you put no. And anyway, human distribution, hip extension, there's no human distribution. It's all about flexors only in the lower limb. And what is the muscle that is responsible for hip extension? Gluteus maximus. Gluteus maximus. Remember, gluteus medius and minimus are more for internal rotation of the hip and adduction of the hip. Adduction is obturator, that is adductors only. But gluteus medius and minimus are more for internal rotation. To some extent, they adduct the limbs also. Okay, so this is gluteus medius and minimus, but maximus is the prime hip extensor that stabilizes the hip while walking. That's why whenever somebody walks, butt becomes very prominent. Natural. So you have to, I mean, more than seeing the actual thing, you have to see the anatomy and the beauty behind it. I mean, I'm not talking about the physical beauty, I'm talking about the anatomical beauty. Okay, so how beautifully everything has been designed, isn't it? What is the root value for this? L5S1, and there is no reflex associated with that hip extension and by sciatic nerve. So remember, the posterior compartment of the thigh is sciatic nerve. Medial is your obturator, anterior compartment is femoral, posterior compartment is sciatic nerve. That's all. Then coming to hip flexion, of course, it will have a good human distribution because it's a flexor of the lower limb, and root value is S1. It has no reflex for hip flexion. S1 in the sense they are supplied by whom? Hamstring muscles. I have a lot of aversion towards hamstrings because I was once upon a player and I used to get recurrent hamstring injury, and because of that I need to discontinue my sport. So I don't like hamstrings. What are the hamstring muscles? The gastrocnemius. What are the hamstring muscles? Semitendinosus, semimembranosus. Yes. These are the hamstring muscles. Then what is the nerve that is supplying the hamstring muscles? Sciatic nerve. Okay, this is not hip flexion, it's knee flexion. Knee flexion. Okay, then you have knee extension. Knee extension. Knee extension, of course, has a reflex. We know, knee jerk. And it doesn't have any human distribution because it's an extensor. And of course, it is supplied by whom? Sorry, I'm writing here. Femoral nerve. And who's going to take care of the knee extension? Quadriceps femoris. You have four muscles: vastus lateralis, medialis, intermedius, and your rectus femoris. Okay, so these muscles. Root value L3, L4. Femoral nerve itself is L2, L3, L4 only. So L3, L4 supplies the knee extension. Then you have something called ankle dorsiflexion. Ankle dorsiflexion. So dorsiflexion is a kind of extension only, please understand. Plantar flexion is the true flexion. Dorsiflexion is a kind of extension. So dorsiflexion has a very good human distribution, human supply. And what is the muscle that is responsible for dorsiflexion? Tibialis anterior. You can expect tibia dorsiflexing towards tibia means there should be an anterior muscle that is pulling. So it's tibialis anterior. Who is supplying the tibialis anterior? Deep peroneal nerve, which is a branch of sciatic nerve only. Deep peroneal, sciatic continues as common peroneal. Common peroneal divides into deep peroneal and superficial peroneal. Superficial peroneal is going to supply the aortas, and the deep peroneal is going to supply the tibialis anterior, which is a principal inverter. Right? That's all. So it's a deep peroneal. Then what are the root values for this? Ankle dorsiflexion, it is L4, and there's no reflex associated with ankle dorsiflexion. And you have ankle eversion, and there's no human distribution for this. And what is the muscle that is responsible for eversion? You have peroneus longus and peroneus brevis. It's also called as fibularis longus and fibularis brevis, and supplied by superficial peroneal nerve. As I told you, these are the principal aortas, superficial peroneal nerve, and root value is L5S1 for superficial peroneal and for ankle eversion, and it doesn't carry any reflex. And you have ankle plantar flexion, which carries a reflex in the form of ankle jerk. Ankle plantar flexion. As I told you, plantar flexion is a kind of flexion of the lower limb, so it will not get any significant human supply. And next we have S1 and S2, ankle plantar flexion, because it is by two muscles called as gastrocnemius and soleus. Okay, one is on a flexed knee, one is on an extended knee. Based on whether knee is flexed or extended, plantar flexion will be predominantly by gastrocnemius or soleus, any one of the muscles. But both are ankle plantar flexors. And you have a reflex. What reflex you have? Ankle jerk. And it is by tibial nerve. Okay, tibial nerve is a branch of sciatic nerve only. Sciatic only goes into tibial and common peroneal. Common peroneal further divides into superficial peroneal and deep peroneal. And then you have great toe extension. This is very important because one of the common areas of lumbar disc prolapse is L4, L5 region, where L5 root may be compressed. So in that situation, the great toe extension will be affected because it's supplied by L5 root. That's a very important point actually. You don't have any big supply and you don't have any reflex associated with that. And now is deep peroneal because the muscle is extensor hallucis longus. EHL, extensor hallucis longus. This muscle is very, very important for plantar reflex. Okay, because to get a positive Babinski, you need extensor hallucis longus. If you don't have extensor hallucis longus, you will not get a positive Babinski at all. You will not get great toe extension because they will ask you what are the cause of negative Babinski, despite the fact the patient is having UMN. One is damage to extensor hallucis longus. One of the points. If there is the damage to extensor hallucis longus, you will not be able to get a Babinski response, no matter what you do. Isn't it? That's why that is a very important muscle, at least for Babinski perspective. So how you will be able to understand the reflexes? I used to tell something called, all of my juniors, there's something called inverted reflex man. So that is one concept. So first draw a guy. Okay, and what we are going to do is we are going to reverse him. Okay, so what you are going to do is just write 1, 2, 3, 4, 5, 6, 7, 8. That's all. It's done. Why? Yes, 1 and 2 is equal to ankle jerk. L, 3 and 4 is equal to knee jerk. Yes or no? Then C, 5 and 6 is for biceps and brachioradialis. C, 6 and 7 is for triceps. And C8 is for what? Finger flexion. That's all. Okay. Am I right or wrong? Correct, no? S, 1 and 2 ankle, L, 3 and 4 knee jerk, C, 5 and 6 for brachioradialis and biceps, C, 6 and 7 for triceps, and C8 for finger flexion reflex. These are now quite simple and straightforward. So generally you will get these things only as questions. They will ask root value for reflexes. They will ask how to elicit reflexes. Plantar. This is what they're going to ask. Okay. Now moving to individual dermatomes. This is very important for sensory testing. Okay. Where will you test for C4? Start from C4. C4 is tested in the acromioclavicular joint. Okay. C4 is best tested in the acromioclavicular joint. That is the best testing portion for C4. Where you test for C5? C5 is best tested near the deltoid prominence. So you put injections, no? In the deltoid. You would have received COVID shots and all. Where you have got, here or back? Here. So deltoid area. C5. Where you test for C6? C6 in the lateral part of the forearm, especially just below the antecubital fossa. This is the antecubital fossa. Just below that, the lateral part of the forearm, you need to test for C6. Then C6 can also be tested in the thumb area also, because thumb is also supplied by C6. Then C7 is with middle finger. The best area to test is middle finger. C8, the best area to test is the little finger. And T1, the medial part of the antecubital fossa, just below the, medial part of the forearm, just below the antecubital fossa. And T2 is the axilla. T2 near the axilla. That's where you do it. So I'll tell you pretty easily. It actually goes round and round like this. That's what it's easy to understand. So if you start with it here, C4 in the acromioclavicular, C5, C6 in the thumb, C7 in the middle finger, C8 in the ring finger, and T1 in the medial part of the forearm just below the antecubital fossa, and T2 in the axilla. That's all over. Just go round on U. That's all. Because in the earlier phases and all, our dermatomes have been in the part of a cylinder and our arms came out like that. No? So that's why it took that shape. That's the reason. So it's easy to understand. Okay, that's why we got it. That U shape. Clear? Do you understand? And certain other important dermatomes are going to be your T4, okay, usually near the nipple area. T4 generally around the nipple area, in and around the nipple area. That's another important dermatome. And T10 is for umbilicus. That's very important. Other things are not that important as far as upper body is concerned. But these three are very important. C6, C7, C8 in the hand. C6, C7, C8. Very, very important. In fact, these questions have been asked so many times. See, I told C5, C6, C8. No, she's telling like this. These days, girls, my God. Okay. That is upper limb dermatome. So once you know about upper limb dermatome, everyone would have known about the brachial plexus. So there are certain nerves that are coming at the trunk level. There are certain nerves that are coming at the root level. There are certain nerves that are coming at the cord level, and there are certain nerves that are coming out as terminal branches. But more importantly, that's why brachial plexus and all is given in any anatomy textbook. But the problem is you won't read it. That's why I'm reminding you. Yes or no? So there are only two nerves that are coming from root level. One is long thoracic nerve of Bell, and second is dorsal scapular nerve. These are only two nerves that are coming at the root level, as you see. That is long thoracic nerve of Bell and dorsal scapular nerve. And there are multiple nerves that are coming at the cord level. In that, one important nerve is the lateral and medial pectoral nerves. Okay, because they supply the pectoralis major. Actually, they are coming from the cord level. Then you know the terminal branches: axillary, median, radial, ulnar, musculocutaneous. In that, two nerves end at the upper arm level itself. That is musculocutaneous and axillary. Other three nerves go down and extend their supply throughout the upper limb. That is median, radial, and ulnar nerve. As simple as that. And what are the two nerves that? What are the two nerves that come at the root level? That's what I'm going to say next. So this is the pattern of sensory loss in patients with brachial plexus injury. But if you have an idea about dermatome itself is enough. For example, if you have involvement of the upper roots, C5 and C6. C5, C6 is upper root. Where you will get the sensory loss? On the lateral half of the U. If you get the lower root, C8 and T1 involvement, where will you get? Medial half of the arm. That's all. There's nothing. Why that is important? C5, C6 and C8, T1. Because we even now see in road traffic accidents. If it's upper root involvement, it will result in Erb's palsy. If you have a lower root involvement, you will result in Klumpke's palsy. So that's why this is important. In Erb's palsy, the sensory loss pattern will be like that of upper roots. In Klumpke's palsy, the sensory loss pattern will be that of lower roots. That's why that is important. Just by seeing that, you can answer. Where is the sensory loss pattern? In a complete plexus involvement, you will not have only the axillary area and the medial arm will be spared, because brachial plexus does not include T2. That's why. Then coming to the nerves from the root. What are the two nerves? Dorsal scapular nerve and long thoracic nerve of Bell. Dorsal scapular nerve supplies the rhomboids. This is a very, very important technique to test for rhomboids. The examiners are extremely like biased towards this. How to test rhomboids? You have to keep the arms behind like this. Okay, behind like this, and that is because of rhomboids. And from there, you need to try to push the examiner's hand behind. I will try to give resistance from behind. You have to try and push like this. Okay, this is the test of rhomboids. So if you are sitting in the chair, try to keep your hand behind and try to push the chair behind. So that is rhomboids action. It is dorsal scapular nerve, C5, C6, as we all know. Then we have long thoracic nerve of Bell for serratus anterior. So the classical description is weakening of the scapula. After 90-degree abduction also you can test, but shoulder abduction also. But most important is this weakening of scapula. Here this patient is having a right long thoracic nerve of Bell palsy or serratus anterior paralysis is there. So his right side, the scapula is winging and it is coming towards the other side. Okay, long thoracic nerve of Bell is C5, C6, C7. Then coming to the nerves from the trunk level. So you have supraspinatus. I mean, you have suprascapular nerve and other nerve, but suprascapular nerve is going to supply two muscles. Both supraspinatus as well as infraspinatus will be supplied by suprascapular nerve only. So how will you test for supraspinatus? I told you initial 15-degree abduction is what is that? Done by supraspinatus only. And after 15-degree only, your deltoid comes in. So you can check the initial 15-degree abduction with this action. Then infraspinatus, how will you check? How are you going to check infraspinatus? You are trying to externally rotate, because one of the important prominent actions of infraspinatus is external rotation of the arm. Okay, so for external rotation, this is very, very important, infraspinatus. Then what are you testing for here? Yeah, it is given there itself, pectoralis major, because pectoralis major has two, what is that? Heads. One is clavicular head and this sternocostal head, because it goes around like this. Okay, it has multiple, you would have seen in many anatomical diagrams also. So how will you test it? So one way to test pectoralis major is to doing this action. Okay, so this is pectoralis major's action. So you have to push the arm like this. So against resistance, you can see the pectoralis major. Okay, that is a way to test pectoralis major. Then, one second, I think my pencil is out of charge. Okay, now it's working. 1 second. 28%. Good. Okay. That's why I couldn't write anything. Okay, next. So next thing is like one more important function of pectoralis major is adduction. Patient is adducting the arm here. So from outside portion is trying to adduct the arm. So that also is done by the pectoralis major, but this is done by sternocostal head. Then what are the nerves from the cords? As I told you, we have thoracodorsal nerve and we have subscapular nerve and we have that lateral and medial pectoral nerves also. And latissimus dorsi is supplied by whom? This thoracodorsal nerve. C6, C7, C8. And how you are going to test for latissimus dorsi? Arm should be in upper position and you should try to adduct the arm. Okay, that is latissimus dorsi, adducting the arm like this. Okay, this is latissimus dorsi. You can see the prominence of the latissimus dorsi in the back. Okay, then what about teres major? Again, you have to adduct only, same, but in the elevated arm, but arms should be straight. So that is how to test for teres major. Then coming to musculocutaneous nerve. We know musculocutaneous nerve supplies only these three muscles. The most important of all this is going to be biceps brachii. So it supplies only three muscles: biceps, coracobrachialis, and brachialis. So in that, the biceps is the most important muscle. So as I've told you already, if you are flexing the arm in a fully supine position. That is for biceps. But in a semi-pronated position, it's for brachioradialis. And suppose if you have injury to one of the nerves called lateral cutaneous nerve of forearm, as the name itself implies, you're going to have sensory loss on the lateral part of the arm. So because initially we saw about the dermatomes, I mean, initially dermatome in the sense that is coming from the root value, but our nerves are mixed nerves, which means that sensory roots are also carried by these nerves, and at certain areas their sensory division will come out. So while coming from the spinal cord, you have motor root, sensory root. Everything comes as a mixed nerve, and as it comes out, it gives rise to motor fibers, and then it will give rise to sensory fibers as well. One such nerve that comes from the musculocutaneous nerve is the lateral cutaneous nerve of forearm. As you can see here, musculocutaneous nerve gives rise to lateral cutaneous nerve of forearm, and that is going to supply the lateral part of the forearm, as we all know. In certain areas, these nerves become very important, because if you talk about the sciatic nerve, the terminal branch of sciatic nerve is saphenous nerve. So why saphenous nerve is important? Just for example, I'm telling. If you do a coronary artery bypass grafting, when you are taking a great saphenous vein, patients will suffer from saphenous neuropathy. It will affect the nerve of that area. I mean, which is affect the distribution supplied by saphenous nerve. That is the medial part of the leg generally. On the other hand, if you have meralgia parasthetica, yeah, where the lateral cutaneous nerve of thigh will be involved. Okay, so in that situation, the lateral part will have burning sensation, all these things. So that is why this anatomy is also very important when it comes to neurology. So this for biceps, and this is the sensory loss. And axillary nerve, again, it's very simple and straightforward. Axillary nerve is going to supply only this thing, that is the deltoid. So you're going to test the deltoid by asking the patient to abduct at a 90-degree position, from somewhere around 90 degree. So you can see the prominence of the deltoid as usual. And if you have an axillary nerve involvement, you will have a small patch of sensory loss in the area where you're going to put injection, the same area. That is called regiment patch sign. Yes or no? So usually axillary nerve may be involved in the proximal fractures of humerus, generally. We can suspect. So this is for the radial nerve. As you can see, no need to mug up all these things. Radial nerve anyway is going to supply every single extensor. Only two things that additionally you need to know is brachioradialis and supinator. Okay, these two additional things are supplied by radial nerve. These are the only two additional things you need to know: supinator and brachioradialis. That's why that's the two things you often forget. Remaining everything, all the extensors are supplied by radial nerve only. So this will be the sensory loss patterns if radial nerve is involved. So why? I'll tell you. First, radial nerve below the elbow, it gives rise to a structure called posterior interosseous nerve. Okay, below the elbow, radial nerve gives rise to something called as posterior interosseous nerve. So if the radial nerve is injured above the elbow, then you will have a wide range of sensory loss. So it will be like a stripe from the arm itself, it will come. But on the other hand, if you are going to involve below the elbow, means you are going to only involve the superficial radial nerve. Okay, that superficial radial nerve is going to supply only a portion in the hand area, in the dorsum of the hand. So that is why this sensory loss pattern will tell you what is the site of radial nerve injury, whether it's high radial nerve injury or whether it is low radial nerve injury. Usually in high radial nerve injury, which means generally we define as injury above the origin of posterior interosseous nerve, or injury above the elbow, or maybe in the spiral groove in the humerus. So somewhere in that area means it will be a big sensory loss, because posterior interosseous nerve itself supplies certain areas in the posterior region. Suppose in low radial injuries, where you will be affecting only the superficial radial nerve, which is supplying a little bit part on the dorsum of the hand. So this is the area that will be affected. And remember, whenever a particular cutaneous nerve is involved, there will be a lot of overlaps. You cannot expect exactly one particular area to be involved. There will be small area may be involved depending on the developmental differences in the person. And what they are trying to check here? They are trying to check the triceps muscle strength. So what you're going to do, you're trying to extend the arm against resistance. Clear? So that's what we're trying to do. This is for triceps. And brachioradialis, what they're trying to do? Brachioradialis, they're trying to flex from a semi-prone position. That is how you test for brachioradialis. And supinator, it's very simple. Okay, you're trying to supinate the arm from a pronated arm. So if the arm is pronated, you're trying to supinate. So from here to this position against resistance. Okay, this is supinator. And radial nerve supplies many other things also. Like for example, here you have extensor carpi radialis. How will you test for extensor carpi radialis? How will you test? See, it's an extensor carpi radialis. So you should extend along with radial deviation. So both should be done. If you do against resistance, you will be able to feel the tendon easily. And next is extensor carpi ulnaris. Same, but ask the patient to extend and deviate towards the ulnar side. Or ask the patient to deviate to the ulnar side and then extend. So if you do it against resistance, you will be able to see the tendon. Nicely, you can feel the tendon here. That is for extensor carpi ulnaris. So then you have extensor digitorum. Of course, it will be supplied by whom? Radial nerve only. There is absolutely no doubt about that. So remember, extensor digitorum goes up to the level of metacarpophalangeal joints. So you have to stabilize the proximal and distal interphalangeal joints first. Then you have to look at the metacarpophalangeal joints. So ideally, you are trying to see the extension of the metacarpophalangeal joints, not the other areas. Then you have abductor pollicis longus, which is supplied by radial nerve as well, posterior interosseous nerve, abductor pollicis longus. So remember, thumb has two different planes. This is adduction, this is abduction, but this is flexion, this is extension. Okay, this is adduction, this is abduction, this is flexion, extension. So you should be very careful in what you are doing. So that is why you need to keep the thumb normally like this. If you are trying to bring the thumb closer to the index finger, that is adduction. If you move away, abduction. On the other hand, if you bring closer to the palm, that is what? Flexion. And if you come back to the neutral position, that is extension. Okay, these are very, very important moments because there is one important sign called Froment sign. I don't know how many of you know that. What is Froment sign? That is, this is a test of actually, Froment sign is a test of ulnar nerve. That's what I'm trying to say. So if you give a paper like this and ask them to hold. So actually they are adducting and they're holding. So this is normal if you adduct and hold. But suppose if they do not have intact ulnar nerve, they have damage to the ulnar nerve, they will not be using the adductor pollicis. So what they do is they will try to use the abductor pollicis brevis and longus. So instead of using that, they will try to do something like this. Okay, flexion, and they will try to hold like this. Rather than like this, they will hold with flexion with the help of other nerves. That's why this is important. Yes or no? Do you understand? So that's why these supplies are very important. Abductor pollicis longus is supplied by whom? Radial nerve. Then extensor pollicis longus is also supplied by radial nerve. Okay, then you have extensor pollicis brevis, which is also supplied by radial nerve. As we all understand, these are all what? Extensor compartment, and everything will be supplied by radial nerve only. So this is how you test extensor pollicis longus and extensor pollicis brevis, by the way. So how will you test abductor pollicis longus? Ask the patient to abduct against resistance. Do you understand? That's all. Okay, then coming to median nerve. Median nerve has no branches in the arm. That's very important. In the arm, they don't give rise to any branches at all. In fact, even ulnar nerve doesn't have much of branches in the arm. But median nerve is main for the forearm. Because in the forearm, ulnar nerve has only two heads of the external digitorum, flexor digitorum profundus, that too on the medial side. So only two heads are supplied. Remaining every muscle in the forearm, in the anterior compartment supplied by whom? Median nerve only. So many muscles are supplied, but I would like to note this, make a note on this palmar branch only. So based on this, we'll be able to say whether the involvement is at the carpal tunnel or above the carpal tunnel. That is why that sensory branch is very important, that small sensory branch. So that's why I told you. If the median nerve injury is above the carpal tunnel, you will get the full-blown involvement, that lateral 3.5 fingers near the thenar eminence. But if the median nerve injury is in the carpal tunnel, okay, because we have carpal tunnel syndrome. That's why if the median nerve injury is in the carpal tunnel, the thenar eminence will be spared. Okay, that is the point. If the injury is above the carpal tunnel, thenar eminence will be involved, and the full-blown lateral 3.5 fingers involvement will be seen. But on the other hand, if the median nerve is involved at the carpal tunnel, your thenar eminence will be spared. That is all because of this escape of this sensory, the escape of this palmar branch of this median nerve. If the injury is at the wrist, the palmar branch will escape. So palmar means this thenar eminence, that palmar branch is supplying this thenar eminence, that will escape. So you won't get sensor loss in that area. Then this is for pronatatory risk, nothing you are going to ask the patient to pronate. That's all. How for supinatory, ask the patient to supinated. Similarly, you are asking the patient to pronate. Nothing much. Then you have flexor carpi radialis. As the name implies, it is flexor carpi radialis, which means what you're trying to do? You're trying to flex, not just flex, but you need to do radial deviation also. So you have to move the wrist towards the radial side and then ask the patient to flex against resistance. That is for flexor carpi radialis. And again, you have a separate flexor carpi. Next one we have to go. Yeah, flexor digitorum superficialis. Remember, almost all of the flexor digitorum superficialis is basically supplied by median nerve only. Only profundus, there will be a small difference between the medial two heads and lateral two heads, but superficialis is supplied by median nerve only. So superficialis is going to supply only up to the level of proximal interphalangeal joint. Only profundus goes up to the level of distal interphalangeal joint. So you have to make sure that you are trying to flex you have to stabilize the distal part, distal interphalangeal joint, and then only you have to ask the patient to flex against resistance. Because if you don't do anything and ask the patient to flex against resistance, you are testing the power of profundus and not superficialis. So you have to stabilize the distal interphalangeal joint, then ask the patient to flex to see the efficacy of flexor digitorum superficialis. That's why that is important. And then you have flexor digitorum profundus. Here you have to stabilize the distal proximal interphalangeal joint, and then you have to ask the patient to flex. Otherwise, you will be testing flexor digitorum superficialis and not profundus. Okay, here if you stabilize the PIP joint, only distal interphalangeal joint will move. So then you will be able to check the profundus completely. But remember, only the lateral two heads are supplied by the median nerve. The medial two heads of FDP is supplied by ulnar nerve. I told you so many times. Then this is flexor pollicis longus. Okay, FPL is very easy to test. So the flexion motion, I told you already, towards the palm. So that is basically by anterior interosseous nerve, which is a branch of median nerve again. And then your abductor pollicis brevis. Remember, abductor pollicis longus is supplied by whom? Radial nerve. I told you some time back. But abductor pollicis brevis is by median nerve. I told you some time ago. What are the loaf muscles? Lateral two lumbricals, opponents, abductor pollicis brevis, and yes, flexor pollicis brevis. Still you are thinking, what is abductor pollicis brevis? Who is supplying it? It is median nerve, of course, loaf group. Then opponents pollicis, loaf muscle, supplied by median nerve. So how will you test opponents? Ask the patient to touch each and every finger, especially the ring finger. Sorry, little finger. If you want to test properly, test for little finger or ring finger. Then you have the first two lumbricals. What does lumbricals do? What does lumbricals do basically? Actually, lumbricals extend at the metacarpophalangeal joint. That's what they do. So that's what we're testing here. Then finally, the ulnar nerve. Lower limbs will be pretty much easier. Only the upper limb will be too much. And that is why no student can easily cross the power examination. Okay, most of the times, if the examiner goes into the details of power examination, it's very tough to pass. Yesterday itself, I told you, no, if at a PG level, if you have crossed power examination, you can be rest assured you are passed. There are so many muscles. If somebody asks you, suddenly if they ask you rhomboids, what do you do? They're suddenly asking you like how will you test for flexor pollicis longus? Suddenly they'll ask you how will you test for flexor digitorum profundus of the ring finger, and who is supplying that? Questions will be like that only. So that too, now at least you can answer something, but in exam tension, what you will do in the examination hall? It's very difficult. Whatever you have studied, you will get confused. And sir, flexor digitorum profundus radial now, sir. Anterior will become posterior, posterior will become anterior. Okay, that's what is going to happen. Okay, ulnar nerve, as I told you, in the forearm, it has only these two. What are these two? Flexor carpi ulnaris and the medial two heads of flexor digitorum profundus. That's all. But this is more relevant clinically. Okay, that's what the question they will be asking you. And apart from that, almost all the intrinsic muscles of the hand are supplied by ulnar nerve, except loaf group of muscles. So ulnar nerve has one important cutaneous nerve called as medial cutaneous nerve of forearm. So now tell me, who is giving the lateral cutaneous nerve of forearm? Wow, great. Muscular cutaneous nerve. So now you have the medial cutaneous nerve of forearm, which is coming from ulnar nerve. Okay, so this will be the sensory involvement if you have a medial cutaneous nerve of forearm. Then this will be the involvement if dorsal cutaneous branch is involved. If the injuries are above the dorsal cutaneous branch, if you see on the dorsal side, it has two branches. Okay, one you have the dorsal cutaneous branch, one you have the palmar cutaneous branch. Then finally you have the superficial terminal branches. So at every level you can predict. So what level the patient, the injury is there in the patient. So if there is injury above the dorsal cutaneous branch, the full spectrum will happen. That medial 1.5 fingers, you would have studied in anatomy. The lateral 3.5 fingers is by median nerve. Medial 1.5 fingers is by ulnar nerve. So the full spectrum you will see only if the injury is above the palmar branch, dorsal cutaneous branch. If the injury is below the dorsal cutaneous branch, so this area will escape. Okay, so this area in the dorsal hand, dorsal surface of the hand will escape because the name itself tells it is dorsal cutaneous branch. If the injury is below the palmar branch, now as the name itself says, it's a palmar branch, so the palm will also escape. Okay, only you will involve the fingers on the medial aspect. Are you understanding or not? That's all. So just by the name itself, you can easily say what's happening. The injury is to the medial cutaneous nerve of forearm, then it's fine. So the injury is little above. If the injury is above the dorsal cutaneous branch, then you will have the full spectrum, medial 1.5 fingers. If the injury is between the medial cutaneous branch, dorsal cutaneous branch and the palmar branch, you will not have the involvement of the dorsal surface of the hand, but remaining everything will be involved. If the injury is below the palmar branch, then only the fingers will be involved, even the hypothenar eminence of the palm also will escape. That's all. And different muscles supplied by ulnar nerve, this is flexor carpi ulnaris. Ideally, this is a way to test flexor carpi ulnaris. You can think this as abductor digiti minimi, no. But in a way, it is flexor carpi ulnaris also important. That's why you put that image. But more importantly, by going by tradition, flexor carpi ulnaris can be easily tested by asking the patient to do ulnar deviation and then flex the wrist. So that is the best way to check for flexor carpi ulnaris. And you can see the tendon also. And flexor digitorum profundus. How will you check? I told you. This stabilization of the proximal interphalangeal joint is very, very important whenever you check the flexor digitorum profundus. And remember, only 3 and 4. Okay, this and this. Okay, are supplied by whom? Ulnar nerve. This 2 fingers flexor digitorum profundus are supplied by median nerve again and again. Then you have flexor digiti minimi also, that is supplied by ulnar nerve. So you can test the flexor digiti minimi there. And you have abductor digiti minimi also, where you are planning to abduct the arms. I'm sorry, abduct the little finger. So you are trying to abduct the little finger against resistance, and you can see the thenar remnants becoming very prominent. That is abductor digiti minimi. These are small muscles of the hand. Because these are small muscles of the hand, every single small muscle of the hand is supplied by ulnar nerve except that lobe group. Then dorsal intraossei. All the intraossei by definition are supplied by whom? Ulnar nerve only. So dorsal intraossei is going to do abduction or adduction? Abduction. So you are going to test abduction of the second finger. Remember, abduction of the thumb is mediated by abductor pollicis longus and brevis. So you have to test the abduction of the second finger only, not the thumb. And palmar intraossei is going to do what? Adduction. Similarly, you should not use the thumb because thumb adduction is based on adductor pollicis and not this intraossei. So you have to use the second finger only for this test. And then you have adductor pollicis. So this is what I was talking about, the Froment sign. So in the Froment sign, adductor pollicis will be defective, indicating ulnar nerve palsy. So the patient will not adduct and hold the paper. Instead, they will use the flexors and they'll be holding the paper. So the thumb will be, and the paper will be held in flexion of the thumb, not in the adduction of the thumb. So that is Froment sign. Yeah, all the muscles are over of the upper limb, done and dusted. That is why I'm telling you, it is not so easy to cross the power examination. Neurology, this is one of the biggest hurdles you can ever see. Okay, so fine. Again, summary, whatever you have learned. So quickly, I'll ask a rapid fire. Who is supplying deltoid? Axillary nerve. Initial 15-degree abduction of the shoulder. Supraspinatus. Loaf muscles are supplied by? Pardon? Abductor digiti minimi is supplied by? Ulnar nerve. Okay. Froment sign is to check for? Ulnar nerve. Medial cutaneous nerve of forearm? Ulnar nerve. Lateral cutaneous nerve of forearm? Muscular cutaneous nerve. What will happen to the sensory loss if the median nerve injury is at the wrist, carpal tunnel? The thenar remnants will escape. Okay. So the patient is having involvement of medial 1.5 fingers, sensory loss is there, but your dorsal aspect is spared. Only the hypothenar aspect and fingers are involved. So what is the likely area of involvement? Between the dorsal cutaneous branch and palmar branch. Okay, if it's below the palmar branch means you will be having only the fingers. If it's above the dorsal cutaneous branch means you will be having the involvement of dorsal area of the hand also. Clear? And what is the reflex root value for biceps reflex and brachioradialis reflex? C5, C6. What is the reflex root value for finger reflex, finger flexion reflex? C8. Okay. All the intrinsic muscles of the hand are supplied by which root? T1. Okay. Abductor pollicis brevis is supplied by whom? Median nerve. Brevis means intrinsic muscle of the hand, and abductor pollicis brevis comes under loaf muscles. So it is median nerve. And abductor pollicis longus is supplied by whom? Radial nerve. Brachioradialis is supplied by whom? Radial nerve. Okay. Then who is supplying biceps? Muscular cutaneous nerve. And who is supplying the supinator? Radial nerve. Who is supplying the third head of flexor digitorum profundus? Median nerve. Okay. Because first two, okay, is supplied by ulnar nerve. The medial two. The medial two is first two. Or maybe whatever. So the medial two is supplied by ulnar nerve. The lateral two is supplied by median nerve. Okay. Flexor digitorum superficial is supplied by whom? In entirety, it is supplied by median nerve only. Flexor digitorum superficialis. Lumbricals is supplied by ulnar nerve because it is intrinsic muscle of the hand. Loaf muscles, yeah. And intraossei, ulnar nerve. Lateral two lumbricals by median nerve. Okay, cool. Flexor carpi radialis. Median nerve. Extensor carpi radialis. Flexor carpi ulnaris. Ulnar nerve. Okay. That's why. Flexor carpi ulnaris is ulnar nerve. Okay. Who's supplying the pronator quadratus? Pronator quadratus. Median nerve. Okay. Cool. Fine. You are good enough to go. And I think if you go with the same knowledge, it's enough for the exam. And how to test each and everything is also practically important. That's why I shown you. So then coming to the lumbosacral plexus, it is actually quite easier compared to your upper limbs. Because lower limbs is not involved in any much fine movements. Okay, but upper limb, your hand is involved in a lot of fine movements. But lower limb, since it's not involved in much of fine movements, it's relatively easier to do. So as we all know, you need to know the root value of femoral nerve. It is L2, L3, L4. So you can, as you can see here, L2, L3, L4 units together to form femoral nerve. This is an easier diagram actually. Then what is the root value for superior gluteal nerve? You have L4, L5, S1. Okay, this is for superior gluteal nerve. And what is the root value for inferior gluteal nerve? L5, S1, S2. It is for inferior gluteal nerve. And as I told you already, sciatic nerve will be dividing into tibial nerve, deep peroneal nerve, and you have the superficial peroneal nerve also. Before that, you have common peroneal nerve, and that common peroneal nerve is going to divide into deep peroneal nerve and superficial peroneal nerve. Okay, so these are the most important nerves of the lower limb. Okay, apart from that, you have ilioinguinal nerve, iliohypogastric nerve, yeah, obturator nerve. There are many other nerves are there that comes a little above, so I'm not going to discuss about that. Most important nerves are these: femoral, then your sciatic, which and its divisions, then your superior gluteal nerve and inferior gluteal nerve. And these are the dermatomes basically. And if you see like this, you will not be able to get properly. I have a different image on how to understand the lower limb dermatomes. So if you look it in that way, it will be easier actually. Let me try to show you if possible. Actually, that I posted on Instagram long back. If you look in this way, it will be much easier, to be honest. As you can see here, how easy it becomes. The L1, L2, L3, L4, L5 segment, S1, S2. So this is how they supply actually dermatome, because our legs come in that direction only, like that. So that's why this becomes pretty much easier and straightforward. If you see where the L1 is, where the L2 is, okay, where the L3, then L4 will come down, L5 then down. Then if you take a U on the side, it becomes S1, S2, S3, S4, S5. Are you able to get it? Yes or no? So if you see in this direction, it's actually quite easy rather than seeing in the traditional direction, because our limbs come from the side only. That's why this understanding. Okay, but nevertheless, where it is for L2. I mean, T10 is for the umbilicus. L1 usually test near the inguinal ligament. L1 we don't do, but if you want to test, you test near the inguinal ligament, L1. Then where will it test? L2. L2 will be tested on the lateral aspect of the thigh. Okay, that is also the site where you have the lateral cutaneous nerve of thigh. So in the same area, you have to test for L2 as well. Where will it test for L3? L3 will be tested in the medial aspect of the knee. That's where it check L3. Where will it check for L4? L4 will be checked in the medial aspect of the leg, generally. Okay, that's where you check L4. Where will you check L5? L5 in the lateral aspect of the knee. That's where you check L5. And where will you check S1? S1 you can check anywhere from lateral malleolus to the sole of the foot. Okay, because the entire sole is predominantly supplied by S1 only. Especially you do plantar reflex, right? You know, you do plantar reflex, right? So that plantar reflex area is supplied by whom? S1 only. In fact, the entire afferent for plantar reflex is coming from S1. Are you understanding around? So that is why that is very important, S1. Then L5, it will be near the great toe. Especially on the medial malleolus, you can check L5. Or near the, sorry, no more than the medial malleolus, it's on the great toe, sorry. Great toe. And the first metatarsal, great toe is there, no? Where you expect that extensor hallucis longus tendon. So I think every one of you will be able to see the extensor longus hallucis tendon. Whenever you put your toe up like this, great toe, you will be able to see a prominent tendon. So that is extensor hallucis longus tendon. If you're able to check there, that's also one of the best sites for L5. That's why I told there itself that extensor hallucis longus tendon and your sensation is also over that area. It is supplied by whom? L5 only. That's a very, very important dermatome as well. And when you go to S2, S3, S4, you will go near the perineal area. So what is cauda equina? I mean, conus medullaris syndrome. I'll tell in a short way in some time, but what is conus medullaris? Conus medullaris means involvement of the conus. That is typically S2, S3, S4 segments. Cauda equina also are going to involve a similar area. That is why you often get something called as saddle anesthesia. What is saddle anesthesia? The area where you sit on your bicycle. So in a bicycle where you sit, that is saddle. So this is the saddle area. Okay. Whenever in conus medullaris and cauda equina syndrome, this is the area where you expect the sensory loss. That's called saddle anesthesia. So you can see S2, S3, S4, and S5 is perianal. Okay. It goes towards that. Lower limb dermatome. So L2 where will you test? Lateral aspect of the thigh. L4 value where will you check? Medial aspect of the knee. Okay, that's where we're going to check for. L3, sorry, I directly jumped to L4. Okay. L2 lateral aspect of the thigh, L3 in the middle aspect of the knee, and L5 lateral aspect of the leg, or maybe over the great toe prominence also. Then S1. S1 in the either lateral malleolus or in the plantar area also, the plantar reflex area also, sole of the foot, but not on the medial side, but go for the plantar reflex area. That is supplied by S1 only. S2 goes to the perineal area, man. Medial aspect of the thigh, and you have to go near the perineal area. Okay, S2 in the posterior aspect of the thigh, but better go to the perineal area. S3, S4, S5, everything. S5 is the most important perineal area. It's immediately around the anus. So if you are touching the area around the anus, skin around the anus, that is S5. Do you understand? Okay, there is something called dermatomal dance also. Have you ever seen what is dermatomal dance? So when you, I mean, there is a Prabhudeva dance and all. So if you do properly, it will come. So where is L2? L2. I'm not going to dance by the way, don't worry. Where is L2? Where is L2? Here. Then where is L3 is here. Then L4 here. Then yes, L3, L4, then L5, sacrum. Okay. That's all. Yes or no? It goes like this. That's why. That's called dermatomal dance. L2, okay, L3, L4, L5, S1, sole of the foot, and your other areas in the butt. Okay, that is the dermatomal dance. It goes like that, opposite. If you want to remember pretty easily, that's one way to remember it. Dermatomal dance. And lower limb nerves are, I mean, muscles and nerves are multiple, but you can easily guess it. So what muscles is supplied by whom? Even though it looks pretty daunting, but actually it's quite simple. Let me come back. So these are the areas of sensory loss if you have a involvement of lateral cutaneous nerve of thigh. Okay, this is the lateral cutaneous nerve of thigh, which is often involved in a disease called meralgia parasthetica. Okay, this will be the area of sensory loss. And femoral nerve, along with the saphenous nerve, because the last branch of the femoral nerve will end up with something called a saphenous nerve. I think I told sciatic nerve. Sorry, I now only got it. So femoral nerve is the one that's going to supply the anterior and the medial aspect of the leg and the thigh. So if you have femoral nerve involvement, this is the area of sensory loss that you will be getting. And if it's an obturator nerve involvement, this is the area of sensory loss that you'll be getting. And if it's a posterior cutaneous nerve of thigh, this is the area of sensory loss that you're going to get, as the name implies. Obturators are adductors, right? So you'll be having sensory loss in the adductor area only. And this is the area of sensory loss if you are having a sciatic nerve lesion. This is the typical area of sensory loss. Because sciatic nerve gives rise to whom? Tibial nerves, and the other sensory nerves that are going to supply the sole of the foot and all. So sciatic nerve is the last one. The S1 and all will be carried by the sciatic nerve only. That is why the entire foot is actually supplied by sciatic nerve in the first place. And if you have a common peroneal nerve lesion, this will be the area of sensory loss, because common peroneal nerve is going to supply the lateral aspect of the foot and then the sole. And if you have a deep peroneal nerve, you will be having involvement of this sandal area, especially when you are holding the slippers. That's very characteristic again. When you are holding the slippers, you will be trying to hold the slippers with what is that buckle, no? So that area of sensory loss, that is supplied by deep peroneal nerve. Remaining other areas are supplied by common peroneal nerve only. Okay, especially on the lateral and the anterior aspect of the leg and the foot. So it's supplied by the common peroneal nerve, except that small sandal gap. I told in Down syndrome also, you mean something called sandal gap. The sandal area is supplied by your deep peroneal nerve. Remaining anterior and lateral portions of the leg and foot are supplied by your common peroneal nerve, and the plantar aspect of your foot is supplied by sciatic nerve. So no, plantar aspect of the foot was supplying sciatic nerve, and the posterior aspect of foot as well. And there is another branch called sural nerve, which is commonly used for biopsying. Okay, they do sural nerve biopsies whenever they suspect neuropathy, especially in congenital neuropathies and all. So if you do those sural nerve biopsies, the sensory loss will be typically in that area, in the lateral aspect of the dorsum of foot. Okay, that's where you're going to get it. And if you have a tibial nerve involvement, you will be typically involving the entire sole. Tibial nerve full of sole. That's where the sensory loss is going to be. And this is the plantar innervation with different nerves, but it's not that important. But as you can see, the lateral part of the foot is sural nerve. So because it is very commonly affected in sural nerve biopsies, that is why that has a little bit of clinical relevance. Other things doesn't have any much clinical relevance, but maybe saphenous nerve, sometimes they tend to ask, because in coronary artery bypass grafting, when they harvest the saphenous nerve, I mean the great saphenous vein, that time saphenous nerve involvement can be seen. So where the patient can tell intense pain and problems in the saphenous nerve distribution, which is the terminal branch of the femoral nerve. Saphenous nerve, because saphenous vein is near the femoral vein, right? And so femoral nerve runs along the saphenous vein only, and of course it ends up as saphenous nerve only. So previously I told, I think it's sciatic. I don't know why I said that, because sciatic is on the posterior side. So that doesn't mean anything. Actually, sciatic ends up with your common peroneal and tibial nerve. So it's not going to end up with saphenous. Femoral only ends up with saphenous. So coming to the power assessment. So this is how you check the iliopsoas. Okay, it is supplied by whom? L1, L2, L3 spinal nerves, and it is supplied by femoral L2, L3, L4 component also, as I've told you in the beginning itself. I think I've told you that. So iliopsoas is important for hip flexion. Yes or no? Remember, your lower limb flexors are very well innervated by upper motor neurons. And this is to check the quadriceps femoris. Quadriceps is a knee extensor. Don't say it is a hip extensor. Hip extensor is gluteus maximus. Yes or no? Hip extensor is a gluteus maximus. So that's what quadriceps femoris does. You are trying to see the knee extension. So here is trying to oppose the knee extension here. So you can see the quadriceps better. Here you can check the adductors. Adductors supplied by what? Obturatus, medial compartment of the thigh. And obviously the examiner is giving resistance for adduction. And what they are doing here? Here they are trying to do something called internal rotation. Okay, gluteus medius and minimus, as I told in the beginning itself, they are internal rotators of the thigh. I think beginning itself I told you this. So the examiner is trying to oppose the internal rotation. And gluteus medius and minimus along with tensor fascia lata can also be abductors. Okay, so you can see when the patient is trying to abduct, you can see what's happening here. Now you can see the muscles prominence, medius and minimus. And gluteus maximus, of course, it's for what? Hip extension. So this is hip flexion. Opposite of that is what? Hip extension. So this is gluteus maximus. Remember, gluteus medius and minimus are supplied by superior gluteal nerve, and gluteus maximus is supplied by inferior gluteal nerve and not superior gluteal nerve. And what they're trying to do here, they're trying to do knee flexion. Knee flexion is supported by hamstring muscles. What are hamstring muscles? Semitendinosus, semimembranosus, and biceps femoris. Okay, who is supplying the hamstring muscles? Sciatic nerve. Okay, sciatic nerve is the one that's going to supply the hamstring muscles. Then power assessment of other things, tibialis anterior. So it is going to do something called dorsiflexion of the ankle, which is supplied by deep peroneal nerve. And here you are testing the extensor digitorum longus, which is again supplied by the deep peroneal nerve. It is like, you can think radial nerve is the extensor of the arm. Like that, here extensor of the leg is the deep peroneal nerve. And extensor hallucis longus once again will be what? Deep peroneal nerve, because it's an extensor. And coming to the reflexes, how will you check for reflexes? Biceps reflex, what is the root value? C5, C6, everyone knows that. So this is the perfect way to check for biceps reflex. You need to hit only on the thumb, not directly on the biceps tendon. And this is the best way to look for the triceps reflex. As you can see here, the examiner is hitting on the triceps tendon. This is the way to test for the supinator reflex, where you hit on the supinator tendon, which is near the radial styloid process. Perfect. And this is the way to test for the knee jerk. So knee jerk can be tested in multiple ways. So one is to hold the knee like this and hit. Second way is to make the patient sit. But why I'm telling this method is because many of your patients may not be able to sit, okay, because of hemiparesis or quadriparesis. So that is why this is one of the best ways to check for knee reflex in a patient who is bedridden, if they cannot sit up. But if they can sit up, then you can sit with their legs dangled down and you can hit the quadriceps tendon as well. And ankle reflex, remember, this is where you have to hit, because after seeing certain unusual sights, I'm saying this, ankle jerk should be hit on the Achilles tendon. And remember to dorsiflex the foot before hitting on the Achilles tendon, because in exam you might not do all these things. Suddenly you might hit on the Achilles tendon directly. So dorsiflex, so that you will be able to see the movement of your hands, where the Achilles tendon striking will result in plantar flexion. This is another way to test for ankle reflex. So patient in prone position and patient is flexing the knee, and from there you can do the dorsiflexion and you can hit on the tendon. So this is another way to check for the ankle reflex. Then we have another way also to test for the ankle reflex. Like this, only the legs are, the distal part of the leg is dangling down. And then you can dorsiflex and you can hit from the top also. This is another way to check for the ankle reflex. And you have the finger flexion reflex, where you are going to press on the tendons of the, long tendons of the finger, hand. Long tendons of the fingers that are passing through the palmar aspect of the hand. So these are the long flexor tendons. So this is finger flexion reflex. What is the root value? C8. Okay, it's not T1, because again, that's a common confusion. People think it is T1, but it's the root value that is supplying the intrinsic muscles of the hand. But majority of the finger flexion is not mediated by intrinsic muscles of the hand. Majority of the finger flexion is mediated by the muscles that are coming from the forearm. Is that no? Flexor digitorum profundus and superficialis. So the root value is C8, not T1. And what about this jaw reflex? What is the root value? There is no root value, because it's carried by fifth, and efferent is also fifth, and the center is pons. Till now, whatever reflexes we saw, the center is spinal cord. So for this, the center is going to be pons. For corneal reflex, center is pons. For pupillar reflex, center is midbrain. What is the afferent for pupillar reflex? Second cranial nerve. What is the efferent for pupillar reflex? Third cranial nerve through the Edinger-Westphal nucleus. Okay. What is the afferent for gag reflex? Pharyngeal gag reflex. 9. Efferent for pharyngeal gag reflex, 10. Okay, so what is the center for pharyngeal gag reflex? Medulla. Yes or no? Okay. So what is the afferent for cough reflex? 10. Efferent for cough reflex is also 10. What is the root center for cough reflex? Medulla again. Do you understand or not? That's why. So many times, in exam, this is how we ask. So when I ask like this, no, the student will be like, where he is asking from? So easy to confuse you. Suddenly, if I go from cranium to hand and hand to foot and then back to cranium, everything is confused. Okay, that is easy to like torture you. Okay, now reflex testing is done. Okay, all the reflexes. So I'm going to ask certain questions now, like rapid fire. So who is supplying the soleus muscle? Soleus. See, where is soleus? Where is soleus? Calf. Calf is posterior, anterior. So what should it supply? Which nerve? Tibial nerve. Okay, posterior. See, tibial nerve is the nerve of the posterior compartment. Common peroneal nerve is the nerve of the anterior compartment. Okay, as simple. Then common peroneal further splits into your superficial peroneal and deep peroneal. So soleus is supplied by whom? Tibial. Who is supplying gastrocnemius? Tibial nerve. Because both soleus and gastrocnemius is going to end up with that plantar flexion. And soleus is the one that basically gives rise to Achilles tendon. Even though gastrocnemius we say, but soleus is the main thing that forms the Achilles tendon. Okay. Extensor hallucis longus. Deep peroneal nerve. Okay. Majority of the extensors of the lower limb are supplied by whom? Deep peroneal nerve. Extensor digitorum. Who is supplying external digitorum? Deep peroneal nerve. Okay, external digitorum is also deep peroneal nerve only. Whatever may be the extensor, it is deep peroneal nerve. Where will you test for L5 dermatome? Where will you test for L5 dermatome? Great toe near the extensor hallucis longus tendon. And who is supplying your peroneus longus and peroneus brevis? Correct. Superficial peroneal nerve. What does the peroneus longus and brevis do? Eversion or inversion? Eversion. Okay. Correct. So you are very clear. Cool. All right. Okay. Fine. So who is supplying adductors of the thigh? Obturator nerve. Who is supplying the hamstring muscles? Sciatic nerve. Wow. Who is supplying the quadriceps femoris? Femoral nerve. Because that is the reflex arc. Okay. Knee jerk reflex. Femoral nerve is the one that is carrying them. Okay. I think it's done. I told you whatever it's needed, it's important. I've told you everything, almost whatever needed for neurological examination. Now, what else is pending? Okay, whenever you come to the motor examination, what are the things that you look for? What are things you're going to look for in a motor examination? Okay, first, bulk, then tone, then power, then reflexes. Okay, these are things that are going to look. Maybe if you want to say, you can say abnormal movements here also, but it's a common tendency for students to say abnormal movements separately somewhere. Okay, when it comes to bulk, where will you measure the bulk? Okay, you know that. Okay, fine. So where do you test the bulk? But remember, the idea is not like that. The idea is to check at the consistent distance from the prominent bony landmark. So in the upper limb, the most prominent bony landmark is Oligran process. In the lower limb, the most prominent bony prominence is either the medial malleolus or the femoral condyles. Either the malleolus or the femoral condyle. So your idea is to check at a consistent side. Like in both the limbs, you need to check at the same distance. That is the idea. So your books will give usually proformas. Different students will say different things. Some people will say 10 centimeters, some people will say 20 centimeters. It doesn't really matter as long as you are measuring at a consistently similar distance. So no need to mug up these numbers. That's what I'm trying to say. Free that memory and try to use it for something else. Okay. So idea is only to measure at a consistent distance from a proper bony landmark. So that's how you find out the bulk. So very common questions. When you will get wasting? Wasting is common in a element lesion. Okay. Then where will you see no wasting? UMN lesion. And where will you see fasciculation? Element lesion again. And more importantly, fasciculations are more prominent in anterior-Honsel lesion. Rather than element lesion as such, it's extremely prominent in anterior-Honsel lesion. Fasciculations. Okay. How will you test for the tone? How will you test for the tone? Yes, you have to test passively. If they will ask the definition of tone is muscle will be always in a state of some resting contraction. That is what we call it as tone. The state of the muscle which has resting contraction is what we are going to refer it as tone in the first place. It's a state of resting contraction. So commonly what is preferred is the rolling method. Okay, especially for the upper limb as well as the lower limb. Even though you do that flexion, extension and all, the rolling method is supposed to be more easier and more patient friendly and more doctor friendly also. Rolling method is you give the hand to the patient and try to roll around like this. This is more easier and the patient will not get apprehended also. If you do like this and all, patient will start moving his own arms. As if he will think like as if you're trying to, you are asking him to move his hands. He will think like that. So ideally, better try to give him a shake hand and try to roll around. That's more easier. Even in the legs also, you can try to roll around like a log. Then one more way to say what is the tone is, like if you have a knee, just try to lift the knee. Just a sudden lift. Okay, you can observe at the distal part of the leg, in the plantar aspect of the leg. So if the tone is normal, there will be a slight lift in the sole of the foot, but there won't be heavy lift. But if the tone is very high, then even a small push, the entire leg will come up. If the tone is flaccid, the leg will not move above the surface at all. If it is flaccid, just try to give a push, just a firm push. No need to lift it, just a push like this, a sudden jerky movement. So if the leg comes completely off the ground, a little high, that's considered to be a high tone because of the increased tone of the muscle. If the leg doesn't rise little bit also, it's in the same position, means it's a flaccid limb. It appropriately moves a little, a small upward movement is also fine. That is considered to be normal tone. So this all are subjective only. So this is a way to test for the lower limb tone. Clear or not? How will you check for cogwheel tremors? Remember, cogwheel tremors should always be tested in the wrist only. You have to turn the wrist around. So that is the best site for testing for cogwheel tremors. Cogwheel. Okay, rotate around the wrist. That is the site for testing cogwheel tremors. Where will you see cogwheel tremors? Parkinson. I mean, that can be called as cogwheel rigidity also. So what do you mean by cogwheel rigidity? That is a rigidity interrupted by tremors. That's all. Cogwheel rigidity is nothing but rigidity interrupted by tremors in between. So that is cogwheel rigidity. Lead pipe is there is no this thing interruption by tremors, so it will be fully rigid, no matter what. So best site for testing for cogwheel rigidity and tremors is going to be your this thing only, wrist only. That is the best site. Okay. So what are the conditions with increased tone? Hypertonia. Basically human lesion. Okay, we all know that. What are the conditions where there will be reduced tone? Element lesion. These are very basics. I'll tell you the details later on, but these are extremely basics. If you don't answer this also only, it's a trouble. Okay. Then power testing we have discussed already. Remember, you will not tell power for individual muscles. Never do that in exam. You test a movement, because whenever there is a stroke or whatever paraplegia case you're dealing with, the extensor flexor compartment, so that is having more value. That is why I always tell my students to test for movements rather than testing for individual muscles. Individual muscles, they will ask you, that is different. You need to know the anatomy and all. But ideally, you should test for what? Ideally, you need to test for movements only, because that's why I gave that chart. Because there you can see a group of muscles will be involved in movement, certain group will be involved in element. So you need to tell the distribution of weakness. That is why the movement testing is more reliable compared to that of your individual muscle testing. That is having more value in clinical practice. That's why. Then reflexes we have covered already. Okay, all the reflexes we did it. So important. But I didn't talk about superficial reflex, I think. What are superficial reflexes we have? What are superficial reflexes we have? Tell no. Okay, plantar. Then abdominal. Then cremasteric. Then what else? You don't have anything else? Anal. Then bulbocavernous. Haven't you heard of this? Anal bulbocavernous. What do you do in bulbocavernous reflex? So bulbocavernous reflex, what you're going to do, you're going to squeeze the penis. So once you, why you're showing your expression like that? Okay, nothing, just squeeze it. At the same time, you need to do a perrectal examination. When you are squeezing, in the PR examination, you will be able to see the contraction of bulbocavernous muscle. Why that is important? Because in human lesions, that will be preserved. In element lesions, it will be lost. Like conus cauda and all, you may not be able to see the bulbocavernous reflex. But if it's a human lesion above that conus cauda region, probably you might be able to see the bulbocavernous reflex. So that is the reason why they will ask you. Anal reflex is very simple. Just you're going to scratch around the anus. You can visibly see the contraction of external anal sphincter. And you can also do the cremasteric reflex if it's a male, obviously. So where you will touch, you will scratch the medial aspect of the thigh. So once you scratch the medial aspect of the thigh, you can see the testis moving upward. And I think many boys would have tried already. I mean, on the patients, of course, to see the movement of the testicles, sudden movement of the testicles up. So that's a good demonstration of cremasteric reflex. Root value L1, genital branch of genitofemoral nerve. So, but the most important thing comes in the plantar reflex. Okay, that is the most important. So, I'll show you a video later on. Okay, but what is happening in plantar reflex? Okay, is discovered by Joseph Babinski, and plantar reflex has become so popular during his time. In the around 1890s, he told that plantar reflex. I think around 1895 or 96. But during that time, it becomes so popular that everyone have come up with one reflex in their own name. That is why Oppenheim, Chaddock, Bing, so Muniz, Throckmorton, so much of science are there. I'll show you a video because I cannot really help it. I'll show you a video in a while. But plantar is the number one thing that is important for exams. But as a postgraduate or a undergraduate, finally they will go into the other equivalents of plantar, like Throckmorton, then your Bing sign, then your Chaddock, Muniz, and all these things. And finally, they will ask you upper limb equivalents of plantar. What are they? Wartenberg, then Tromner, then we have one more. I'll show you. Okay, 3 signs we have. These are the upper limb equivalents of plantar. Why that is important is because the examiner will specifically ask you if the patient is amputated bilaterally and is having a human lesion. How will you find out? Okay, third one is Hoffman sign. So Wartenberg, Hoffman, and Throckmorton. Sorry, Tromner. So 3 signs are very important. Okay, fine. So now let us see the plantar reflex first. So where you are going to scratch in the lateral aspect of the sole of the foot. It is supplied by what nerve root? It is supplied by S1. And who is supplying, which nerve is supplying that area? Tibial nerve. Do you remember that? Tibial nerve is the one that entirely supplies the sole of the foot. And it is supplied by root value called S1. And when you are examining for plantar reflex, the leg should be flexed or leg should be extended. Or leg should be in what position if you are going to extend for, if you are going to look for plantar? Pardon? In what position? Legs should always be in extended position. And you should never try to flex the legs. The reason is because if you are talking about a human lesion, your flexors of the lower limb will be affected. And the legs will naturally be in the extended position only. So that is the best position for assessing the plantar reflex also. Are you able to get it or not? So many people try to flex, do something. So nothing, but you have to expose the entire limb. That is very important. On the other hand, you should always try to do it in the extended position only. Like whatever the patient's natural position is, the same position you can do the plantar. And you should not touch the ball of the foot. Okay, you should go up to the ball of the foot, but you should not go beyond the ball of the foot. And you have to take a nice arc. So let me show you that. Okay. So here, if you see, is there any flexion or any abnormal position here? Patient is in what? A very natural position. What is the natural position? Patient is in a very natural position. What is the natural position? Extension. Is there any flexion of the limb? No. Not at all. So what is the response you're getting? Extensor response or flexor response in that patient? What response you got? My God. What response you got? Extension. So what is this? We are now talking about Gordon sign. These are the plantar equivalents. Other equivalents of Babinski. So what you are doing here, squeezing the calf muscle. See, you get the same response. Clear? So squeezing the calf muscle is what we call what? Gordon sign. So what is this one? Chaddock's. So what they're doing in Chaddock, they are scratching on the lateral aspect of the foot. Okay. Can you see one more time? What is the response you're getting? Extensor, same response. Okay, scratching on the lateral aspect of the dorsum of the foot. Chaddock. Then Schaffer sign, deep pressure on Achilles tendon. So same thing, like how you gave a deep pressure on the calf, like that you are going to give deep pressure on the Achilles tendon. This is Schaffer sign, same response. Can you see? Yeah. Then Oppenheim sign. What are you doing? You are going to give a pressure down the shin of the tibia. Can you see that? Almost similar response. Ding sign. You are going to do a pin prick on the dorsum of the foot. Moni's sign. Forceful plantar flexion at the ankle. If you do a forceful plantar flexion at the ankle, but you should not try to, cover up the toes. Leaving the toes, you have to just press the ankle down. So that is going to be. Then you have this Trumpel sign. You're just going to give a firm pressure over the anteritibial region. You got a very mild response only. Then you have Stransky sign. Small toe will be forcibly abducted and flexed. So you can see here, forcefully abducted and sudden release. It's like a flicking of the small toe. This is called as what? Stransky sign. Okay. Cool? Fine. Then finally you have two more signs. Cornell sign. Stroke on the medial border. Okay. Near the extensor hallucis tendon. You get the same response. And Gonda sign. Snapping the second toe. Just snapping. Then Zapiro sign. You're going to use the second to fifth toe and you're going to flex them. Then Throckmorton sign, percussion over the dorsal aspect of the first MTP joint. And Cleckley sign. Again, flicking of the second toe. Clear? You have so many signs are there. That's all. Totally 14 signs as plantar equivalents. These are all extremely important questions. Okay, even though I've showed you in 2 minutes, but all these are extremely important. And finally, this is what is going to decide your pass. Take my words. Okay, if you don't answer anything at all, okay, finally, like you forgot everything you got confused, something happened to your brain. Finally, your pass will be decided by plantar reflex. That's why you have to know everything about plantar reflex. Do you understand? Okay, all the signs I have showed, whatever you have written, you can go and revise it later on. And what are the plantar equivalents? I've asked you, no? You are going to tell me what is this sign? What is this sign? What is this? This sign is called Wartenberg sign. So it's a Babinski equivalent in the upper limb. So what we are trying to do here, we are trying to pull the patient using these fingers, and normal response is extension. Even you can try with your friend. Yeah, same thing. You can try with your friend. You try to make a fist and pull. Your finger will extend only. Your finger will not flex. Okay, your thumb especially will not flex. It will extend and abduct only. Yes or no? That's what it will happen. But this patient will be flexing, and finger will be curved like this. Okay, so this is what we refer to as Wartenberg sign. This is a plantar equivalent of the upper limb. Then one more sign. Two more, in fact. This is called as Hoffman sign. Flicking the middle finger will result in flexion of the second finger. It will not happen to you, happen to her. This will happen only in patients with Yeoman lesions. Flicking the middle finger. Just flick. Just a simple flick, that's all. Can you see that? So this is Hoffman sign. We have another sign. It's just a variation of Hoffman sign. That's called Tromner sign. Here you just they're also going to flick only, but it will be a slightly different flick. That's all. So here you are flicking from the bottom. That's all. Same response. Okay, that is what Tromner sign. Tromner. See, what are the upper limb equivalents? Wartenberg, Hoffman, Tromner. Flicking from top is Hoffman. Flicking from down is Tromner. Wartenberg, like how you do Jendrasic maneuver, something like that. So normally, see, if you think and do, something else will come. Normally, if you do for a normal person in the road, suddenly being like that, normal response is involuntarily your hand will go out only. That's a normal response. Even you can try with anyone. But if they flex and try to adduct, so that is called as Wartenberg sign. These are all Babinski equivalents of upper limb. Usually, finally, this is how it will terminate your exam. Last but not the least, they will come to the plantar. So you tell the plantar equivalence, upper limb equivalence of plantar. If the patient is bilaterally amputated, how will you test for plantar? And if you don't know this, they will go and stand like this. If the patient is bilaterally amputated, how will I do plantar? They will ask like that only. The patient is amputated bilaterally, how will you do plantar? What you will tell? You will think examiners are mad. You don't have legs at all. How can you do plantar, man? So you will think something and you will say something. Sir, I will pinch the knee, I will prick the knee, I will do on the knee, something you will say in the amputated limb. That all is wrong. You have to go for upper limb testing only. Okay. So what are some of the precautions as far as plantar reflex is concerned? First, you need to assess the thickness of the sole. Thickness of sole is important, and the sole should be warm. And knee should be always extended, as I told you multiple times. You should not flex the knee. Knee should be always in extended position only. And legs should be straight or flexed. Legs should always be straight. And you need to test the power of extensor hallucis longus before you perform it. Because without extensor hallucis longus, you cannot get this test done at all. So you need extensor hallucis longus. So if you take all the precautions and if you expect the response, what is the normal response you get in a normal person without human lesion? Flexion of all 5 toes. All 5 toes. This is the normal response you get. But even though you get flexion of all 5 toes, your concentration, your vision should be only on what? Great toe. You should not see anything else. Even though the normal response is this described as per the textbooks, but you should look only at the great toe, nowhere else. Then you will have dorsiflexion and inversion of foot also, plus or minus. Sorry, plantar flexion and inversion of foot also. Plantar flexion and inversion of foot. Plus or minus, you can have flexion of knee and hip also. Which means everything is a flexion response. That's what I'm trying to say. Okay, everything is a kind of flexion response. These are additional responses which you might get. So this is the reason why we always wanted the entire leg to be exposed. So you cannot just expose the plantar region and do the reflex. You want the entire leg to be exposed, basically. Then there is something called as Brissot reflex. What do you mean by Brissot's reflex? There will be contraction of tensor fascial lata, adductors of the thigh, and sartorius muscle. Adductors of the thigh and sartorius muscle. So this is called as Brissot's reflex, otherwise called as minimal plantar response. Sometimes you may not get the normal response. Instead, you might get a minimal plantar response like this. That minimal plantar response is what we called as Brissot's reflex. And even this is considered to be a normal sign only. And what do you mean by extensor plantar? Extensor plantar. That is called Babinski sign. Even though we call it as Babinski positive, Babinski negative and all, there is nothing called Babinski negative or positive. It's just Babinski sign. That's all. So first one is going to be extension of great toe. Great toe extension. This is the most important. Plus or minus, you can see fanning of all the other toes. All the other toes fan out like that. Plus or minus, you can see dorsiflexion of ankle as well. Dorsiflexion of ankle as well. So this is opposite of what you got in the normal response. The normal response, you got plantar flexion, inversion, and toes cluster each other with flexion along with the great toe. But here, the great toe is extending, toes are fanning out, and there is a dorsiflexion at the level of the ankle also. So what are the areas where you'll get a positive Babinski? In the sense, your Babinski sign will be there. Number one, Human lesion, any pyramidal tract lesion, Human lesion. That's the number one cause. And less than 1 year of age, infants may show positive response. Infants less than 1 year of age. Patients who are in deep coma. So whenever pyramidal tract is sleeping, in all those times you might get a positive Babinski response. Then if the patient is under general anesthesia, not local, but general anesthesia, because your pyramidal tract will be sleeping again. Number 5, if the patient is having significant hypoglycemia, again because the dysfunction of the pyramidal tract, it's a metabolic problem. Then in the post-ictal state, after seizures. So these are the usual areas where your Babinski may be positive, apart from the Human lesion. What are the conditions where you get no response? So the most usual reason, according to many textbooks, is faulty technique. Faulty technique, okay? Second is thick sole. Third is cold feet. And fourth, that's why you have to warm the feet before doing it. So fourth is peripheral neuropathy. Presence of peripheral neuropathy. Fifth is S1 myelopathy, because S1 is the one that carries the entire information of the sole of the foot. So in S1 myelopathy or neuropathy, S1 myelopathy and neuropathy, you might result in absent plantar. Or if you have EHL paralysis. Okay, extensor paralysis, longus paralysis. So in this situation also, you may not be able to get any response whatsoever. Okay, these are the areas where you might not get response. And whenever you have a Human lesion, what will you expect? Whenever you have a Human lesion, your reflexes will be brisk or reflex will be lost? Reflex will be brisk whenever you have a Babinski. But there are some conditions where there will be plantar extensor, but you will have absent ankle rest, absent ankle jerk. This is again a very important question. What are the areas where you can have an extensor plantar, but ankle jerk is absent? What are the conditions? One, if you have, anything that affects the spinal cord, along with anything that affects the peripheral nerve also. Technically speaking, it is SACD because of B12 deficiency, subacute combined degeneration, where it affects the corticospinal tracts and posterior column. Along with it, it's going to affect the peripheral nerves also. So B12 deficiency can affect both spinal cord and the peripheral nerves. That's why. Second similar congenital condition is Friedreich ataxia. So here also you will have involvement of both corticospinal tract in the spinal cord. Along with it, you will have involvement of the peripheral nerves also, causing peripheral neuropathy. And third, if you have a combined cauda-cona syndrome. So you have either conus medullaris or cauda equina, but if you have a combined cauda-cona, you might experience something like this. Or if you have a tabes dorsalis, sometimes it's possible. And HIV patients are prone for this because HIV can cause both myelopathy as well as neuropathy. Okay, in HIV patients, it is possible. They can get combined myelopathy as well as neuropathy. These are all very famous questions. Extensor plantar with absent ankle response. Okay, now I told you almost all the important plantar equivalents, by the way. And at least you need to know 5 in the lower limb. So tell me some 5 in the lower limb. Oponym, Chaddock, Bing, Schaffer, Moniz, Throckmorton. Fine. So at least 5 to 6 you should be able to say out of all with what I have described. Then Allen is there. So whatever you want, you can say. Stansky sign is there. So whatever, at least 5, 6 you should be able to say. Then what are the upper limb equivalents one more time? Wattenberg, Hoffman, Tromner. Okay. So these are the things that you need to know for sure, for exams at least. Okay. So coming back to the tone, what are the conditions that produces increased tone and what are the conditions that produces decreased tone? So what is the minimal thing that you should say? Human and element. That is the least minimum, and everyone will say, there's no doubt about that. But apart from that, what are the conditions that can increase the tone greatly? One is your anxiety. Patients who are very anxious. Okay. Patients who are extremely anxious may have a very high tone. That's why we use that Gendrasic maneuver and all to reduce the thought process towards the test that what we are doing. Second, if you have an extrapyramidal lesion, extrapyramidal tract lesion. So in extrapyramidal lesion, you will get two types, that is cogwheel type and lead pipe type. Okay, cogwheel, I told you, it is a type of increased tone that is interrupted with tremors, whereas lead pipe is uniform rigidity. And what is the difference between the UMN pyramidal lesion that produces the clasp knife spasticity? What is the difference between clasp knife spasticity and your rigidity, cogwheel or lead pipe? Because since I told you your UMN will specifically target certain group of muscles, your spasticity also will be in those specific group of muscles only. Clear? I mean, in the sense like the opposite group of muscles. That's where your spasticity is going to be. Am I right or wrong? But in patients with extrapyramidal lesions, the rigidity will be distributed uniformly, which means the hypertonia will be distributed uniformly. They will not target any particular muscle or muscle group per se. So this is what we call as rigidity. That's the major difference between spasticity and rigidity. And what do you mean by clasp knifing? What do you mean by clasp knifing? As you increase the force, for example, if the patient is having a UMN lesion like this, I mean UMN palsy, and they are having a hypertonia like this, what you're trying to do is you're trying to open up and you're trying to push the limb forward. So what happens in this situation is your stretch reflex arc will get activated. The reason why they're having hypertonia is activation of this gamma motor neuron discharge, and I'm not going to talk about the physiology, and that is what is causing that hypertonia basically. And normally itself stretch reflex arc will be active for you and me, but these patients will have a oversensitive stretch reflex. So if you try to stretch, actually that stretch reflex will get more and more activated. Okay, they will start producing too much of contraction, and it becomes almost impossible to stretch the arm or leg or whatever part you are trying to. But if you are giving too much of force, like as I told initially, as you give force and force and force and force, the contraction is going to oppose you more and more. At one point, what will happen? A protective reflex called as Golgi tendon organ reflex will start. So that is a kind of an inverse stretch reflex. So that's a protective reflex. So once the Golgi tendon organs are activated, because Golgi tendon organs will get activated only after too much of stretch. It's a protective reflex for the muscle to prevent the damage to the muscle per se. So as the Golgi tendon organ reflex gets activated, it is relaxed. The limb becomes a little loose. So towards the end, you will feel lesser stiffness. So that is what we call as clasp knife spasticity. Clear not? That is because the initial continuous overactivation of the stretch reflex causing more and more contraction, opposing your passive movement. After some time, you will find less resistance at the end of the maneuver because of the activation of Golgi tendon organ reflex, which is an inverse stretch reflex. That's all. This is the reason for clasp knife spasticity. But in extrapyramidal lesions, you will not feel anything like that. There will be uniform rigidity, not just in one particular group of muscles, in all the group of muscles involved in that area. That is rigidity. In that, how will you differentiate between cogwheel and lead pipe? By looking for the tremors. Cogwheel will be interrupted by tremors. Lead pipe will not be interrupted with tremors. Then fourth, maybe you can say tetanus probably. So that is another cause where you can have elevated tone. Likewise, you have multiple causes for elevated tone. Okay. So what are the conditions that produce hypotonia? Hypotonia. Of course, you are going to get hypotonia with element weakness. That is what we refer to as flaccidity. Apart from that, if you are ingesting a neuromuscular blockade, or if there is a neuromuscular blocker poisoning, what are the neurological causes apart from that? Cerebellar lesion, well known to cause hypotonia. One of the important effects of cerebellar involvement is hypotonia. And then patients are having chorea. This is again a very, very important topic. One of the important signs of chorea is hypotonia once again. Number 5, patients who are having UMN, but in spinal shock stage, very acute stage. So it's a well-known fact that UMN in acute stage will have hypotonia only. Later on, as the time progresses only, they will get hypertonia. There is another phenomenon called as Gegenalten. Have you heard of that? Gegenalten. So what do you mean with them? Gegenalten or Gegenalten? And it is like clasp knife spasticity, but it's a little opposite. I'll tell you how to differentiate with clasp knife and this one. So as you give more, more force to release the muscle, the resistance will keep increasing. There will be no clasp knife effect at the end. And this will not be there for only one group of muscles. Everywhere you do, this will happen. So this is not rigidity. Why it's not rigidity? In rigidity, there should not be any increase in the tone as the force increases. In rigidity, the tone will be uniform. It will be increased, but it will be uniform. There is no increase or decrease because of your action. But here, as you keep giving more force, the tone keeps increasing. The limb will become increasingly rigid. It becomes very difficult to move. And this happens in all groups of muscles. Where you will see that? Dementia patients. You can think they will voluntarily resist your movement. Somebody who voluntarily resists your movement, this is what you will see. They will not allow you to do any movement. Not only in the upper limb, in the lower limb, or in the arm, forearm, in the legs, wherever you do, they will not allow you to do. So that is what we call as Gegenalten. So second important thing is decorticate and decerebrate rigidity. So again, this needs a lot of understanding, but I'll tell you only a few salient points that are important for exams. If you talk about decorticate rigidity, the lesion will be above the level of the red nucleus. Above red nucleus, typically at the superior colliculus level. Typically at the superior colliculus level. Lesion will be above the level of red nucleus, basically. Decorticate. Whereas in decerebrate rigidity, the lesion will be below the red nucleus or below the superior colliculus level. Below the red nucleus, or you can say below the superior colliculus area. In the midbrain, somewhere. Decorticate rigidity will produce flexion of upper limbs but extension of lower limbs. Whereas in decerebrate rigidity, there will be universal extension of all limbs, upper limb as well as lower limb. Universal extension of all upper limbs as well as lower limbs. If you want to understand this, it's actually pretty simple. I'll try to explain in a very simple way. If you have a brain stem, let us assume this is the midbrain and you have a red nucleus here, and you're going to have, maybe it's crosses basically. So these are rubrospinal tracts. Rubrospinal tracts are basically for flexion of the upper limb. It helps a lot in flexion of the upper limb. Because you know, pyramidal tract tries to extend. They supply the abductors and the extensors. Okay, so this is basically going to cause flexion. And there are many other extrapyramidal tracts. Let me say, so much other extrapyramidal tracts are there, like tectospinal and reticulospinal tract. So many extra tracts are there. So these tracts are basically trying to extend the upper limbs and the lower limbs. So what your pyramidal tract does is, pyramidal tract actually inhibits almost all of these extravertebral tracts. They won't allow these extravertebral tracts to work in the first place. In the sense, they will be working, but they will be under control of pyramidal tracts. Whenever you have a pyramidal tract lesion, these tracts will get released. Okay, if the rubrospinal tract, if the lesion is above the red nucleus, and if the rubrospinal tract is intact, there will be flexion of upper limb and extension of lower limb. That is what we call as decorticate rigidity. Suppose the lesion is below the red nucleus, but in the brainstem only, but if it's below the red nucleus, your rubrospinal tract also will go, resulting in no flexion of the upper limb and universal extension of the lower limb. I mean, upper limb and lower limb. Do you understand? So that is what we call as decerebrate rigidity. But whatever may be the case, if there is any sort of posturing, it indicates brainstem is intact. Any level of posturing indicates what? There is something in the brainstem. That's why it has a very important legal implication that with posturing you cannot declare brain death. Even if the patient is having decerebrate posturing, even though it indicates a bad prognosis, but you cannot declare brain death because it indicates some activities going on in the brainstem. Some extrapyramidal tracts from the brainstem are still working. So legally you cannot declare the patient as dead. That's why it's had a lot of implication, to be honest. But whenever you talk about tone, or if you get a coma case, surely they will ask you. Okay. Some people expect you to answer above the red nucleus, below the red nucleus. Some people will expect you to answer above superior colliculus, at the level of superior colliculus, something like that. So it doesn't matter, but concept is the same. This is what happens. So whenever they talk about tone, you have to talk about this also. Do you understand? Yes or no? Okay. So now small break, 10 minutes. You can come back. We are going to finish CNS by 7, and till 8 you will have respiratory system, until 9 you will have abdomen. Okay. I have a separate PDF for that. I have to finish that. And respiratory system, I have given exactly what you should say in exam. That table which I have given, no, that will tell you exactly what you should say in examinations. Clear or not? Okay, you can go and come.